Hello and welcome back to MedSynapse podcast, where we bring you insightful conversation with leading experts in medical field. Hi, I'm your host, Dr. Smarika Bhatt, and today we have special guests with us, Dr. Ramanaprasad with us. Dr. Ramanaprasad is a reputed senior pulmonologist with more than 12 years of experience in treating patients with various lung disease. He is well known for diagnosing and treating conditions such as allergies, asthmas, or snoring. He is currently working as a consultant interventional pulmonology and sleep specialist in KIMS Hospital. Welcome, Dr. Prasad, to the podcast.
Yeah, thank you very much for that nice introduction. Thanks again for having me here.
Thank you so much. So let's jump right in. We will start with our first topic, which revolves around GINA 2024 recommendation. So how do you balance GINA 2024 recommendations with the practical constraints of resource limited settings, particularly regarding diagnostic equipment availability with the medication access?
Actually GINA is the term, so if we elaborate it, it is called as Global Initiation for Asthma Treatment. So every year there will be new guidelines. So the GINA 2024 clearly identified the lacunae in medical equipments and even the availability of the medication. So most of the rural places still doesn't have proper devices, medical devices for the diagnosis. And coming to the asthma, the gold standard diagnostic test is spirometry. So generally we'll call it as lung function test. If that is not available, then getting to a complete conclusion about the diagnosis of asthma becomes a little bit tricky. But in those places where the diagnostic tools are not available, GINA will be looking at other alternatives at the same time about the medication also. So all of us know asthma has the symptoms like breathing difficulty, cough, other chest tightness, and medications like antihistamines, bronchodilators, and ICS. So some places these drugs may not be there. So during that kind of a situation, we need to look for other alternatives.
Okay, that's really insightful. So speaking of adaptation, what modification have you implemented in peak flow monitoring protocols for patients when spirometry access is limited? How does this affect your clinical decision making?
Yeah, so that's what I told you. For diagnosis, proper diagnosis of asthma, whether it is cough-variant asthma, it is a severe asthma, or even difficult to treat asthma, the simple and important diagnostics tool is to have a spirometry. Some places still doesn't have this spirometry available. So in that kind of a situation, we'll be depending on peak expiratory flow. That's called as PEF meter. It's just a blowing device with some marks on it, which tells us how much the patient is able to blow into that machine. So though this PEF meter cannot replace the spirometry, where it is not available, the spirometry, we can use the PEF. And here the important thing is we need to train the patients how to do that PEF meter at home and to record the values. So if they are properly trained, then either they will be doing it on daily basis or daily twice basis, and they will be recording the values on a paper. If they see any changes, means definitely we'll be telling about the reference ranges and values. If the reference range values are not happening whenever they are doing that test, then it is an indication that their asthma is going out of the control and they are going to experience exacerbation. So that's the time where they should be seeing the doctor.
Okay, so as we have touched upon spirometry, let's move on to the allergen immunotherapy related questions. So based on recent evidences, how do you prioritize candidates for allergen immunotherapy in adult asthma when considering cost constraint or long-term outcomes for it?
First, we should go a little in depth into the asthma treatment. If we see the treatment of asthma, the first and foremost thing is a bronchodilator followed by inhaled corticosteroids, and some of these patients will be requiring antihistamines also to keep their symptoms under control. Even after giving proper medication to them, still some of the patients may be having issues, particularly with allergic rhinitis, where they will be coming to us with running nose, sneezes, and nose blocks, and sometimes they have even continuous wheezing happening. So at that time, we'll be advising them to go for allergy testing so that they will know what exactly the triggers that are causing their asthma go out of control. So once we find out the exact allergens, then we can ask them to go for immunotherapy. So that is immunotherapy is also very much specified to few allergens only, particularly to the house dust. If the patient is suffering mostly because of the house dust allergens, then once we start immunotherapy, definitely their symptoms will come under control. So we need to identify the patients for immunotherapy. We cannot give immunotherapy for each and every patient. So patient identification is very much important.
Okay. So, a more often misunderstood topic that is called asthma management pediatrics. So, how do you approach FE1 and FVC ratio interpretation in children when dealing with the technical limitation and varying references value across different ethnic population?
So yeah, coming to the spirometry itself, doing a spirometry in pediatric age group is very difficult because it needs some technique to be followed. So the technician should be very good and he should be in a condition to explain the proper technique to the kid. Then only they can able to reproduce that technique. If they are not in a position to do it, now we have a better spirometry that are available, which are called as IOS, impulsive oscillometry. That is a specialized spirometry where even the kid is very small, less than 5 years also, we can do the spirometry test for him. But going back to the rest spirometry and that FEV1 and FEVC ratios is very, very difficult to interpret in children because of the ethnic groups and because of the difficulty in following the commands of the technician. So we have to take into consideration the patient's symptoms, age, and their ethnicity, and we should come to a conclusion in terms of their symptoms and their disease progression.
Okay. Thank you so much, Dr. Prasad, for joining in. It was a lovely discussion regarding the pediatric asthma management and you covering the spirometry angles of diagnosing of the patients. And thank you to our viewers for tuning in. And remember, if you are a healthcare professional who is eager to delve deeper into medical topics or have questions, do not hesitate us to join on MedSynapse platform. MedSynapse platform is not just a resource, it's a dynamic space where you can connect with your medical peers or participate in meaningful discussions or contribute to the ongoing evolution of healthcare. So until next time, stay healthy, take care.